احنا اخر اليوم وتو سم اب، يعني تقريبا احنا كاننا هنسم اب بعض الحاجات اللي اتقالت. هل الريسبيراتوري انفكشنز ان بريجنانسي، هل البريجنانسي ده مختلف؟ يعني هل البريجنانسي ستيت دي از ان اميونو كومبرومايزد ستيت شويه مختلفه؟ هل هيكون فيها بعض الاختلافات في البكتيريال انفكشن، في الفيرال انفكشن، في التوبركلوزس، في الكوفيد؟ هل الدراجز مختلفة؟ هل الراديولوجي هيكون فيه اختلافات؟ ده اللي هنشوفه وهنجري بسرعة بقى، لأن معظم الكلام اتقال النهاردة الحقيقة بشكل وافي جدا. الكاب والهاب والفاب والبكتيريال والفيرال هو الكوفيد بقى اللي ظاهر زهقنا منه، فما كانتش سيرته قوي النهارده. اتعمل له حاجات كتيره قبل كده. والتوبركلوزس برضو اتاخد بشكل وافي جدا. دي بريجننت وومن، نفسنا كلنا البريجننت وومن تبقى بالشكل ده without any respiratory tract infections، لكن ساعات بتجيلنا في العياده I can't take my breath، وبيبقى في عندنا respiratory tract infection. هل الاميونولوجي في البريجننسي ده زي modulated immunity في البريجننسي؟ Immunology of pregnancy is a unique host graft response. سبحان الله، لأن إحنا محتاجين يبقى فيه characterized إن هو يبقى immune suppression to tolerate a genetically foreign fetus، وفي نفس الوقت but at the same time maintains immunity to other pathogenic infections. المعادلة الصعبة دي هتتعمل إزاي؟ There is a shift from cell-mediated immunity to humoral immunity. T helper 1 to T helper 2 shift due to migration of these cells to the maternal fetal interface and action of progesterone, estradiol, and prostaglandin D2, which also promote T helper 2. The T helper 2 increased secretion of interleukin 4, interleukin 10, monocyte colony stimulating factors, leading to immunosuppressive effect. Treg cells increase in number during pregnancy and can be found in blood and lymph nodes, have an immunosuppressive action, and help in maintaining the maternal-fetal tolerance. Altered responses to respiratory infections and increased severity of infections. Many infections can be more severe and lead to death of the fetus and of the mother. Increased susceptibility to viral, bacterial, and parasitic diseases, mainly due to suppression of the cell-mediated immunity due to the shift from T helper 1 to T helper 2. Pregnancy causes changes in the mother, significant alterations in normal physiology, affecting respiratory and cardiovascular systems. Respiratory failure in pregnancy presents a unique challenge. ومعنا أستاذ دكتور محمد عبد الحكيم يعني ملك الرعاية. Ventilating two systems using one set of diseased lungs. Delivery requiring ICU 0.2 ل 0.4% of pregnancies. Respiratory failure فيهم من 40 ل 50%. 1% of ICU admissions are due to admitted majority postpartum females pregnant. Respiratory physiology. Hormonal changes during pregnancy affect upper respiratory tract and airway mucosa, leading to hyperemia, mucosal edema, and hypersecretion. Estrogen effect leading to capillary congestion, tissue edema, and hyperplasia of mucous glands. Expanding uterus displaces the diaphragm, but with normal function and excursion. This cartoon shows the physiological changes that happens in pregnancy and the volumes that it changes in pregnancy. And this cartoon shows the anatomic effects leading to airway edema and friability, and this leads to difficult intubation of the pregnant woman. widened AP and transverse diameter, elevated diaphragm, widened subcostal angle, enlarged uterus, and functional effects: increased respiratory drive, minimal change in TLC, increased tidal volume and reduced FRC, increased oxygen consumption and CO2 production by the fetus. Pneumonia, bacterial pneumonia. Pneumonia was diagnosed in 30% of pregnant women with severe sepsis. When they are diagnosed already having severe sepsis. Pneumonia is associated with adverse fetal and maternal outcomes, including maternal mortality. Decision is required to differentiate CAP, HAP, and VAP, and empiric antimicrobial treatment needs to be carefully chosen. If chest radiograph is not available, CAP is defined as symptoms of an acute lower respiratory tract illness and at least one of the systemic features, new focal chest signs, bronchial breath sounds, and/or crackles, no other explanation for the illness. And if there is a chest radiograph is available, symptoms and signs as above with new radiographic shadows with no other explanation. تعريف الهاب والفاب كل ده احنا عدينا عليه. Other potential causes of acute respiratory failure during pregnancy include pulmonary edema, asthma exacerbation, pre-eclampsia, eclampsia, aspiration, pulmonary embolism, transfusion reactions, amniotic fluid embolism. Should be taken in consideration these differential diagnoses in the pregnant woman. It's not only pneumonia. Risk factors for infection with MDR pathogens include this topic was برضو كان قلنا عليه قبل كده. Chest radiograph should not be delayed in the clinical setting of pneumonia. Abdominal shield must be used in the pregnant, and resolution of the chest radiographic abnormality may lag behind the clinical response. Routine chest radiograph for follow-up is not warranted in patients who improve clinically. Point of care ultrasonography. Lack of radiation exposure and rapid assistance in decision making. الراديولوجي في الآخر الملخص للراديولوجي don't avoid necessary studies and don't do unnecessary studies like daily chest X-ray. لأن الرادز اللي بتتعرض ليها they are very minimal in the chest X-ray, in the VQ scan, even in the CT pulmonary angio. Management tips. Low threshold for ICU management of pregnant patients with severe pneumonia. May receive close fetal maternal monitoring. Overhydration may increase risk of pulmonary edema. Semi-recumbent position to minimize risk of aspiration. Low dose hydrocortisone if septic shock, poorly responsive to fluid and vasopressors. Oxygen. Modality of oxygen delivery may be chosen based on response, higher oxygenation, saturation 95 or PaO2 more than 70 is desirable in pregnant patients, ensures fetal oxygenation. Principles of mechanical ventilation in pregnant patients with severe pneumonia and ARDS include low tidal volume ventilation with minimization of airway pressures, prophylaxis for DVT unless contraindicated. Avoid tetracyclines and clarithromycins and fluoroquinolones in pregnant women. In fungal pneumonia, diagnosis and management is similar to non-pregnant adults. Underlying immunosuppression include uncontrolled diabetes, hematological malignancies, and hematopoietic cell transplantation and solid organ transplantation. Invasive fungal pneumonias, mostly caused by Aspergillus, and others include mucormycosis. Risk factors for fungal pneumonia include severe neutropenia, glucocorticoids, immunosuppressive drugs, and AIDS. In pregnancy, fungal pneumonia may be considered if specific underlying risk factor for fungal infection is present and in patients with non-resolving pneumonia. Antifungal therapy essential for treatment in pregnancy is embryotoxic, but life-saving in critical cases of unresolving pneumonia. Candida preferred therapy is caspofungin. Fluconazole may be acceptable alternative. Amphotericin is recommended in patients with suspected azole-resistant candida, and duration of treatment is about 2 weeks after culture negativity. Influenza. Influenza and influenza-like illness can be caused by various diseases, including influenza, respiratory syncytial virus, SARS-CoV-19, and drugs. Influenza may be fatal in pregnancy, and every pregnant woman should be vaccinated by influenza vaccine. Drugs that cause flu-like symptoms include interferons, monoclonal antibodies, chemotherapeutic agents, anti-tuberculous drugs, and levomazole. Risk factors for adverse outcome include immunosuppression and pre-existing comorbidities like diabetes, cardiac, chronic renal disease, and malignancy. Pregnant patients who come to the hospital for delivery, both confirmed or suspected influenza infection, should be isolated in a separate room and initiating immediately the antiviral therapy while awaiting for the diagnostic testing. Separation from the mother until the mother received antiviral medications for 48 hours or afebrile for more than 24 hours without antipyretics. Cough and respiratory secretions are under control. Pregnant and postpartum patients who meet current case definition empiric treatment with appropriate influenza antiviral medication should be initiated irrespective of vaccination status. Influenza vaccine is not 100% protective. These are the treatment for influenza and the doses. Pregnancy poses a unique problem in management. Two circulatory systems to be ventilated simultaneously. Limitations to adequate ventilation during pregnancy include difficult intubation due to the gravid uterus. Prone ventilation is not possible. Sustained paralysis is not possible due to risk of deformities to the fetus. Need for a higher FiO2. Airway pressure release ventilation may be used as an alternative to conventional mechanical ventilation. Tuberculosis طبعا ده يعني محتاج محاضرة كاملة TB in pregnancy and TB in women, لكن it's one of the 3 leading causes of death in women في 15 ل 45 years old. TB in pregnancy is associated with increased chances of abortion, preterm labor, prematurity, low birth weight babies, preeclampsia. Early initiation of antimicrobial treatment reduces obstetric morbidity. HIV co-infection is the strongest risk factor for progression of latent TB to active TB disease. Immune response to TB bacilli increases HIV replication, rapid progression of HIV disease. Over 50% of maternal mortality in women with tuberculosis is due to co-infection with HIV. Non-treated TB is more hazardous to the mother and fetus compared to the treatment of TB. Treatment of TB, suspected tuberculous pregnant should start immediately the treatment, and is not an indication for the termination of pregnancy. Antituberculous drugs, isoniazid, rifampicin, center barrier, but with low risk adverse effect. Streptomycin, contraindicated, and second-line antituberculous drugs consider drug interactions and teratogenic effects. Chemoprophylaxis is safe. Isoniazid تمام. يعني الباقي فيه إعادات. ممكن نقول جزء الأنتيبيوتيك. Antibiotics misuse in pregnancy is a far graver problem even than the antimicrobial resistance in the population, causing the risk of resistant bacteria, risk of potentially teratogenic effects, including spontaneous abortion. Information regarding safety and efficacy generally not available from randomized controlled trials. Pregnancy is often standard criteria for exclusion from clinical trials. Safety profile available for only 10% of medications marketed. Antibiotics, 25% in pregnancy, using 12.5% in the first trimester. Although indications for maternal antibiotics sometimes justified, potential risk linked to their overuse and misuse that exceed their benefits. Unindicated antibiotics are prescribed in about 45%. Antibiotics alter maternal and neonatal intestinal microbiota, major role in the maternal and child health outcomes, such as immune and metabolic functions later in life, potentially altering risk of development of childhood asthma, atopy, obesity, neurologic disorders. Prenatal systemic antibiotics, significant predictor of asthma by 3 years of age, increased risk of epilepsy in childhood, and greater risk of hospitalization due to infection in the first 6 years. And thank you.